So hello everybody, today we are going to learn about the fracture of tibia and fibula. As you can see the fibula and tibia bones. The tibia bone consists of three parts, that is the upper part, middle part and the lower part. The upper part consists of the lateral and medial condyles. The middle part consists of the shaft which joins the two parts of the tibia. The lower part consists of the lateral and medial malleolus. Tibia and fibula. Tibia is the largest bone in the lower leg. It accepts majority of weight-bearing forces compared to fibula during physiological gait. It says that it acts as a weight-bearing force, that is, total weight of the body is supported by the tibia bone. Hence, it is most frequently fractured bone in the human skeleton. Also, the fibula serves primarily the point of attachment for tendon and ligaments. Because of dense cortex of the tibia means there should be a large force acting to yield a fracture because the cortex part of tibia is very dense. Mechanism of injury. The tibia and fibula may be fractured by a direct or an indirect injury or trauma. Indirect injury, it can be road traffic accidents. These are the most common cause of these fractures, mostly due to direct violence. The fracture occurs at about the same level of both the bones. Frequently, the object causing the fracture lacerates the skin over it, resulting in an open fracture. So, we'll now see what is an open fracture. An open fracture it is an injury where the fractured bone are exposed to the external environment via a traumatic violation of the soft tissue and skin. Then the direct trauma, direct force to the tibia often produces a transverse or comminuted displaced fracture with associated fibular fracture. Here in the picture we can see that there is a tibial shaft fracture. It is a type of transverse fracture. As you can see, only one bone is involved, and also the direction of force is in a single direction, and it is fractured into two parts. In this X-ray, you can see that it is a comminuted fracture. That is, there are multiple fractures present in the tibia. Also, along with tibia, there can be fibular fracture because, as we know, that the two bones consist in middle of the two bone it consists of interosseous membranes. So, whenever there is fracture of tibia, there are more chances of developing fractures of fibula. Indirect trauma, indirect torsional force. It may result in spiral or oblique fracture and less likely to yield displaced fracture. The sharp edge of fracture fragment the skin from within, resulting in an open fracture. As you can see in the picture, this is a spiral fracture and also the bone is displaced. Now we'll see the pathoanatomy. The fracture may be closed or open. As we already know that open fracture is an injury where the fractured bone is exposed to external environment via a traumatic violation of soft tissue and skin. Now, now we'll see what is a closed fracture. When a fracture happens, it can either be an open or closed fracture. Closed fracture, the bone is broken but the skin is intact and we cannot see the bony parts. There will not be any external appearances of the broken bone. Hence, it is known as closed fracture. Now we'll see pathanatomy. The fracture can occur at upper, middle, lower third of the shaft. Fracture can happen at upper, middle, or lower third of the shaft. The tibia is commonly fractured at the junction of upper two-third and lower one-third of its shaft because the tibia shaft is narrowest at the junction of upper two-third and lower one-third. Hence, these are the commonest sites of the fracture. The lower one-third of the tibial shaft is bare area and it has a low blood supply. For this, it can be a reason for the fracture in the lower one-third of the shaft of tibia, and it shows delayed union or non-union of the bones after the fracture. And occasionally a single bone can be fractured, as I have already said that whenever there is a fracture of tibia, also the fibula is being fractured. The displacement may be sidewise or angulatory or rotational. The tibia is closely joined to fibula by interosseous membranes and with close proximity of the bone. A displaced fracture of one tends to yield the fracture of another. Symptoms. So now we'll see the symptoms after the fracture. The tibial and fibular fractures often present with following symptoms. There can be extreme pain or unbearable pain, edema of the lower leg, or also known as swelling over the leg, edema over the leg, and obvious anatomical deformity. Assessment. How will we assess the case? This includes periodical assessment of dorsal and posterior tibial pulses, and capillary refill are necessary to recognize the onset of acute compartment syndrome. Noting any symptoms of exaggerated pain, pallor, and paralysis. And dorsalis pedis artery and the posterior tibial artery. These are the two assessment sites for checking the pulses. So you can see that behind your medial malleolus you can assess the pulse, posterior tibial pulse. And capillary refilling. You can assess the capillary refilling in the greater toe. This can be done by applying pressure to one finger or toe for up to 10 seconds. Pressure makes the finger or toe appear pale in color. Release of pressure and time, how long it takes the skin to return to the same color as nearby tissues, capillary. This color change is due to oxygen-rich blood filling up empty capillaries. And radiological features. The diagnosis is usually confirmed by X-ray examination. The evaluation of the anatomical configurations of the fracture on X-ray helps in reduction. The treatment, it can be based upon two types of fractures, that is closed fracture and open fracture. In closed fractures, both in children and in adults, is by closed reduction under anesthesia, followed by an above knee plaster cast. In children, it is possible to achieve good alignment in most cases, and fracture unites in about 6 weeks. So there will be union of bones in about 6 weeks. In adults, the fracture unites in 16 to 20 weeks. Sometimes reduction is not achieved or the fracture displaces in the plaster. In both these cases, open reduction and internal fixation is required. Then, open fractures. The aim in the treatment of open fracture is to convert into a closed fracture by taking care of the wound and maintain the fracture in good alignment. Following methods can be used. This can be based upon grading of the fracture. There are totally three grades. Grade 1, wound dressing through a window in an above knee plaster cast and antibiotics. Grade 2, there will be wound debridement and primary closure. And above knee plaster cast, the wound may need dressings through a window in the plaster cast. Grade 3, wound debridement, dressing and external fixator application. The wound is left open. Now we'll see the complications of fracture. There can be delayed union and non-union, malunion, infection, compartment syndrome, injury to major vessels and nerves. In delayed union and non-union, the fractures of tibia sometimes take unusually long time to unite, more so one in lower third, because as we know that in lower one third of the shaft the blood supply is very less. In some cases there can be clear signs of non-union on x-rays. In that, the most important factor responsible for delayed and non-union is precarious blood supply, that is blood supply of the tibia. The other factors can be loss of fracture hematoma, wound infection, etc. Failure of union results in pain and inability to bear weight on the legs. So in this case, the, the treatment of delayed union and non-union is essentially by bone grafting without internal fixation. There can be following treatments: nailing with bone grafting, femister grafting. So in nailing of bone grafting, it is indicated in case of non-union where the alignment is not acceptable or there is free mobility at fracture site. Some surgeons prefer plating and bone grafting. And femister grafting, it is a type of grafting done for selected cases, like if there is minimal or no mobility at the site of fracture, or there is an acceptable alignment at the site of fracture, or the knee joint has a good range of movement. In femister grafting, it is performed without disturbing the sound fibrous union at the fractured site. In this, the aim is to stimulate bone formation in the fibrocartilaginous tissue. The cancellous bone grafts are placed after raising the osteo-periosteal flaps around the fracture. In addition, petaling, that is lifting slivers of cortical bone attached at the base, is carried out around the fracture. This results in bony union in about 3 to 4 months. I will see the second point, that is malunion. There will be some amount of angulation acceptable in children as it gets corrected by remodeling. In adults, displacement, especially angulations and rotations, are not acceptable. These cause problems in walking and results in early osteoarthritis of the knee and ankle. The treatment requires is the correction of the deformity by redoing the fracture and fixing it by plating or nailing and bone grafting. Let's see the third, infection. Because of frequency with which tibial fractures are associated with the communicating skin wound, the contamination and subsequent infection is a common complication. So most often the infection is superficial and is controlled by dressing and antibiotics, but also sometimes the underlying bone gets infected, in which case more elaborate treatment on lines of osteomyelitis may be necessary. The fracture in such cases often does not unite. Next is compartment syndrome. In some cases of closed fracture of tibia, it may be associated with significant crushing of the soft tissues, leading to compartment syndrome. A compartment syndrome should be suspected if a fracture of the tibia is associated with excessive pain, swelling, and inability to move the toes. Immediate operative decompression of the compartment is imperative. Now we will see what is compartment syndrome. Compartment syndrome can be occurred due to trauma. It happens typically after long bone fractures, and the tibial fractures are the most common cause of the condition. So, the compartment syndrome is there will be increase in pressure inside a muscle which restricts blood flow and causes pain. If it happens suddenly, it can be serious and need treatment as soon as possible. And fifth, injury to major vessels and nerves. Occasionally, a fracture of tibia, especially in the upper third of the shaft, may be associated with injury to the popliteal artery or common peroneal and tibial nerves. Therefore, examination of neurovascular status of limb in a fresh case is of vital importance to prevent serious complications like vascular gangrene. I will summarize quickly. So, whenever there will be fracture of tibia and fibula, the tibia are the weight bearing forces compared to fibula during a physiological gait. Fibula serve as a point of attachment for tendons and ligaments. Because of the dense cortex of tibia, there will be large force necessary to aid a fracture. Then mechanisms are two types: direct and indirect. Direct trauma, it can be due to road traffic accidents, and there can be laceration of the skin due to and it can lead into open fracture. Direct trauma can be due to transfer or communicated. Indirect trauma, indirect torsional force. It can be spiral or oblique fracture and less likely to yield displaced fracture. Fracture may be closed or open. It can occur at upper middle or lower third of the shaft. Occasionally single bone fracture. Symptoms can be extreme pain, edema of lower leg, and obvious anatomical deformity. We will assess the case by dorsal and posterior tibial pulses by capillary refilling and noting any symptoms of pain, pallor, paresthesia, and paralysis. Then, in radiological, the diagnosis can be confirmed by X-ray examination. Treatment can be of two types: closed and open fractures. Complications can be delayed union and non-union, malunion, infection, compartment syndrome, and injury to major vessels and nerves.